So, good afternoon, everybody, and a warm welcome to everyone who has joined today for this wonderful comprehensive webinar on monkeypox, the new notorious kid on the block. So, monkeypox is a viral zoonosis, a virus transmitted to humans from animals with symptoms similar to smallpox, although clinically less severe. Monkeypox was first discovered in 1958 in colonies of monkeys kept for research, hence the name was given monkeypox. The first human case of monkeypox was reported from Democratic Republic of the Congo in 1970. Monkeypox virus primarily occurs in Central and West Africa. In 2003, the first monkeypox outbreak outside of Africa was reported in the United States of America, which was linked to contact with infected pet prairie dogs. According to WHO, in the present series of outbreaks being reported, this is the first time that chains of transmission are reported in various countries without known epidemiological links to West or Central Africa. More than 75 countries have reported outbreaks of the viral disease with confirmed cases crossing 25,000. Some of the countries where the viral outbreak has been reported include Brazil, Spain, US, Japan, France, Germany, Israel, UAE, and now India. And the WHO has recently declared monkeypox a global public health emergency of international concern. India has recently reported 9 cases of monkeypox so far, 5 in Kerala and 4 from Delhi, with 1 death reportedly due to encephalitis as a complication of monkeypox. So to understand this notorious new kid on the block, we have two eminent speakers today. Dr. Aruna Pujari, Head of the Department Pathology and Microbiology, Breach Candy Hospital, Mumbai, who will speak on virology, transmission dynamics, and infection control. Dr. Kirti Sapnis, Infectious Disease Consultant at Fortis Hospital, Mulund, who will speak on clinical presentation, complications, and treatment of monkeypox. And of course, towards the end, we will be having question-answer session, which you can either type in the chat box or at the end of the session, you can raise your hand and we will invite you to ask your own question. Please remember, this is a knowledge session and there are no CME credit points for this scientific session. So with this, it is my pleasure to introduce our first speaker today. Please allow me to share the screen. So our first speaker today is Dr. Aruna Pujari. She is Department Head of Pathology and Microbiology at Breach Candy Hospital, Mumbai. She is MD Microbiology, DNB Microbiology, and Diploma in HIC. She has many certifications with her. She's American Board Certified in Medical and Public Health Microbiology. She's American Board Certified in Infection Prevention and Control from CIC, Diploma Hospital Infection Control from LSHTM UK, and Diplomat of Royal College of Pathologists UK. She has multiple publications and book chapters to her credit, 44 international and national peer-reviewed publications and 3 book chapters. She has been a teacher for a long time. She is PG teacher DNB for microbiology, lecturer for CPS, DPB, FCPS, medicine and tropical diseases, PG teacher for MSc microbiology research at Mumbai University. She has delivered more than 160 guest lectures on infection control, microbiology, and infectious diseases at national and international CMEs and conferences for different medical societies. So it's a pleasure to have you over here, Dr. Pujari, and a warm welcome to you. And so the stage is all yours. Please carry forward the session.
In US mainly because of infected humans coming across or coming in contact with prairie dogs, and so this keeps on happening in small clusters outside of Africa, particularly in the US, but the present cluster is very different, and there are no epidemiological linkages to Africa, directly to Africa. Then there is also broad cross-neutralization and cross-protection between the viruses of the same genus, meaning that variola, vaccinia, and cowpox may offer some protection to monkeypox, both from the point of view of disease, as well as this might also be important from the point of view of protection. and little or to none is known between, meaning there is little or no cross reaction or cross protection between viruses of other genera. For example, if you look at chicken pox, which also might have a little bit of similar presentation, that's a completely different virus group, and therefore has no cross reactivity or cross protection with monkeypox. So coming to the geographic distribution, and this is a traditional geographic distribution where the virus is actually endemic to Central and West Africa. And in fact, there are two clades that have been described, the West African clade and the Central African clade. And what's important is that the case fatality ratio of the Central African clade is a bit higher than the West African clade. So typically the disease is endemic in the West and the Central parts of Africa. And plenty of outbreaks have been described since 1970 in these African regions, with the primary natural hosts being rodents, squirrels, the Gambian pouched rat, non-human primates being incidental hosts, and similarly even humans actually being incidental hosts when we come across infected animals, primarily because it's a zoonosis, as Dr. Pate also mentioned. This is basically a zoonosis. So how does transmission happen to human beings? So because this is a zoonotic disease, it is mainly because of we coming in direct contact with blood, body fluids, or cutaneous and mucosal lesions of infected animals. So either while handling them or even eating contaminated meat and meat products which are not properly cooked. So that's how often the organism gets transferred from an infected animal to human beings, and that's what is traditionally have been happening in the clusters that Africa has experienced. Now, from human beings to human beings, that is human to human transfer, is basically secondary transmission. And here what happens is when an infected human being comes in contact with another one who is exposed to respiratory secretions, skin lesions, or recently contaminated objects and fomites, it leads to a secondary transmission to another human being. And one infected human being can actually transfer to almost about 6 to 9 people who can further get infected. So this is very important, because when you are doing contact tracing, which is a very, very important aspect of public health response to the current outbreak, you need to trace people 21 days prior, after having come across the primary case. And at least 6 to 9 people one should try and find out who might get infected. And another route of transmission amongst human beings is basically from mother to fetus via the placenta. So these are the common routes and of transmission. And while most of this particular current outbreak is known to happen in MSMs, neither the CDC nor the WHO has really called monkeypox to be a sexually transmitted infection. So it's not yet classified as an STD. So the virus enters the human body through the respiratory tract, through broken skin, even direct skin-to-skin contact, and mucous membranes like the mouth and the eyes. Going on to the current outbreak, and this is the current outbreak where almost 83 countries have actually got affected without any epidemiological linkage to the endemic area or the endemic zone, that is Africa. More than 25,000 cases reported, nearly 11 deaths globally. India till yesterday had about 9 cases and we had 1 death. As Dr. Pate also mentioned. So WHO declared on 23rd July 2022 monkeypox as a public health emergency of international concern. And of course, much prior to that and subsequently, there's been a global response that has come about in order to curtail this particular infection. So what's really atypical about this current outbreak of monkeypox that is happening, it is basically non-endemic spread. So geographically, it has spread across the world to so many countries and all continents without an epi-linkage to Africa, or without an obvious epi-linkage to Africa. The presentation can be quite atypical with just a few or even a single lesion. There could be lesions in the genital and the perineal areas which do not spread further. These lesions could be asynchronous in their stages of development, and lesions which appear much before the onset of fever and the other constitutional symptoms. So this is something that as clinicians, all of you will also need to keep in mind, that the current outbreak could have a lot of atypical presentations. And how is it spread? While most cases have spread amongst men who have identified as MSMs and participating in extended sexual networks, though this is not really exclusive, and there is a possibility we might see other kind of contacts also. So currently, it is close and direct physical contact, which is face to face, skin to skin, mouth to mouth, mouth to skin, with infectious lesions or mucocutaneous ulcers, including during sexual activity. It's of course going to be droplets, because that's also the traditional route of spread, and contact with contaminated materials, which could be linen, bedding, electronics, clothing, and sex toys. So with that background, let's move on to how are we really going to diagnose it in the laboratory. And this again is something which is at least to some extent and some point in time going to be restricted to our national virology laboratories, rather than be decentralized like other diseases. So the government of India has come out with guidelines for the management of monkeypox. And one thing to remember in mind is, whenever you collect a specimen for any kind of laboratory diagnosis, the sensitivity of that test result would largely depend upon the quality of the sample. So if we don't get a good quality specimen, be sure that the results are not going to be appropriate and satisfactory. So based on this guideline from Government of India, they say that for asymptomatic individuals, who just going to monitor them for 21 days to look out for signs and symptoms. Once the signs and symptoms appear, that is, once a patient becomes symptomatic, then during the rash phase, the lesion is to be basically sampled. So it could be de-roofing the lesion and getting the sample. It could be a biopsy. It could be an aspirate from the lesion, a lesion crust. All of these placed in plain sterile test tube or a container. Then nasopharyngeal, oropharyngeal swabs can be taken, and again they have to be placed in a dry tube, not in the viral transport media, which we have been used to for the past 2 years with the COVID pandemic. They also suggest collecting blood, both serum as well as plasma, in appropriate vacutainers, and urine in a sterile urine container. Now, in the recovery phase, if a patient presents or if a patient is being tracked, then blood and urine are to be collected. And mainly, other investigations would be done over a period of time for these specimens. Now, very important as healthcare workers, those who are involved in going to be involved in collecting the specimen, ensure that they wear appropriate PPEs or personal protective equipment, which could include disposable aprons, coveralls, an N95 respirator, because very close contact with a suspected individual might lead to transmission. So healthcare workers really have a hazard. A face shield, safety goggles, double gloves, and a head cap and shoe cover or booties could be used. So similar, I think it's not different for us. The COVID pandemic has given us a lot of lessons and a lot of experience towards collecting specimens and keeping ourselves safe as healthcare workers. Now, this is something very, very important. We know that viruses are very easily become non-viable, So it is very important that after a specimen is collected, it should be stored properly, and it should be transported properly to the site or to the lab where the testing really happens. So another important aspect is going to be, after collecting the sample, if you're going to transport it somewhere, then ensure that it is in this triple layer packaging, which is according to WHO standards, because if it is not done like that, there is a likely chance of a leakage, and it might be a hazard to healthcare workers who are handling it, and it will further lead to spread. So it can become a very important occupational hazard to people who are handling. So if you have just collected the sample and want to transport the sample within a short time, 2 to 8 degrees would be okay. But if it is going to go over a long distance and time, then it is -70 to -80, using dry ice, and dry ice preferably, and definitely a triple layer packing. And whenever any sample is going to be transported from one healthcare place to another, to the testing center. And this is what the ICMR has recommended from the point of view of testing. So clinical specimens, which could be lesion specimens, EDTA, serum, urine, OPS, NPS, will all be tested for orthopox virus, the genus orthopox virus. If this turns out to be positive, then specific PCRs will be done for monkeypox. And if that comes positive, then monkeypox will be reported. And of course, because this particular outbreak has been, all the cases have been linked to the West African clade, thankfully, which has in fact a lower mortality. Next generation sequencing will also be done for positive cases to know whether it is belonging to the West African clade or there is a change in clades. So that's how specimens are going to be processed in India. And the guideline also mentions the primary and secondary contact persons for any queries with respect to sample processing from National Institute of Virology, Pune. So just like the global situation, even in India, there's been a public health response that has been initiated. And this is very, very important to prevent any secondary cases and to effectively manage the current ongoing outbreak. So here there is local rash surveillance in the MSM population and the wider community. There's case searching and active case searching and isolation of these cases at least for 3 weeks. Extensive forward and backward contact tracing to enable source identification, which is very important, and we've not yet been able to find a source yet. And raising awareness amongst healthcare workers, and including sexual health and dermatology clinics. So overall, there's going to be a lot of raising awareness that will be required. And this is one such session that we are all participating in, and I'm happy to be here. So for Mumbai, what really we can do is, there is a CRF form or a case record form that needs to be filled. This is the monkeypox surveillance document, which has come, circular, which has come from BMC. There is also a link where this kind of reporting, all the details of the patient along with the clinical features are to be reported. And one needs to notify to EpidCell Kasturba, and the patient has to be referred to them, and they will do additional sampling and patient isolation. Suggestions would be given by Kasturba Hospital. So this is what we are supposed to be doing at present. It's basically only notification to EpidCell, which is important. So how do we really prevent? And I'm going to talk about in general prevention, and then moving on to the current cluster prevention. So reducing animal to human transmission mainly would include unprotected contact with these wild animals, particularly ones which are sick and dead, and naturally ensuring that meat be thoroughly cooked before eating. How do we reduce human to human transmission? Surveillance and rapid identification of new cases is critical. Close contact with the infected persons with the most significant risk factor. Healthcare workers and household members are at risk of infection, and therefore, whenever handling a suspected case, standard infection control precautions should be taken. Persons who are previously vaccinated against smallpox should be selected to take care of a suspected patient, and naturally sample should be safely packaged and transported. So these are the general measures, and we'll move on to the specific IPC interventions that are needed both in healthcare as well as community settings, which include both standard precautions as well as transmission-based precautions. So isolation remains the key. The moment you have a suspected case, isolation remains the key, just like the COVID pandemic. And here the isolation is a bit more extended. You continue to isolate the patient until the rash is fully resolved, the scab falls off, and a fresh layer of intact skin is formed. So look at this picture F, which is only a partially removed scab. So even at this point in time, the patient should continue to be isolated till a normal skin appears at this site. Okay, so isolation duration can be almost up to 3 weeks. But again, it has to be, one has to go by the patient's clinical features and the lesions. So in the community, what are the IPC precautions that can be taken? And again, I must say that this becomes easier after handling the pandemic for 2 years. Avoid visitors, avoid any close contact with people and pets. Do not engage in sexual activity that involves direct physical contact. Do not share potentially contaminated items like bed linen, clothes, towels, washcloths, drinking glasses, and utensils. It's good enough to wash all these things with warm water and soap. You don't require specific or different disinfection measures, frankly speaking. Routinely clean and disinfect frequently touched surfaces like counters, light switches, door handles, which can easily get contaminated. Wear a well-fitting source control or a medical mask. So here again, if you are doing aerosol generating procedures which don't really happen in the community, it's good to have to wear just a surgical mask, a triple layer surgical mask, for all those people who are actually caring for, or rather this one person who's caring for this suspected patient. Then avoid use of contact lenses to prevent any inadvertent infection of the eye. Avoid shaving rash covered areas of the body, as this will lead to spread of the virus. What else? Again, bathroom usage, if it is preferable to have a separate bathroom, but this may not be, meaning may not be a common situation. And if there is no separate bathroom and it has to be shared, then what is to be done is, after activities like showering, using a toilet, or changing bandages that cover the rash, ensure that this area gets cleaned and disinfected with a local disinfectant that you might have at home. And consider using disposable gloves while cleaning if the rash is present on the hands. So ensure any common spaces that are being used, after use, there needs to be cleaning and disinfection that is happening. So that's about the community settings, and moving on to healthcare settings. So in healthcare, we naturally follow standard precautions, and these standard precautions use hand hygiene. Whether you want to use alcohol rub or wash, soap and water would depend upon the situation. Respiratory hygiene and cough etiquettes, use of appropriate PPE, especially the mask, injection and medication safety, cleaning and disinfection procedures, safe handling of blood and body fluids, safe disposal of sharps, safe disposal of linen, and biomedical waste management, all are part of all of them are part of standard precautions. And this is something that as healthcare workers we practice day in and day out. This is a slide from actually Environment Protection Agency, and they have classified monkeypox virus as a tier 1 enveloped virus. So being tier 1, it's very easy to inactivate this virus and destroy it because it has a lipid envelope. So you don't need any fancy disinfectants. You simply need whatever is available. So your routine alcohol, quaternary ammonium compounds, hypochlorite, whatever is available with you as a disinfectant. Any low level disinfectant would also help in actually destroying the monkeypox virus. And only be sure to follow the recommended dilution and the contact time by the manufacturer. So whatever the manufacturer recommends, 1 in 5, 1 in 100 as the dilution, and the contact time should be followed for the virus to be inactivated. Then transmission-based precautions in healthcare settings, naturally we want airborne, droplet plus contact. In fact, WHO talks about droplet, whereas CDC talks about airborne. And I think having greater protection is important here, because naturally on day 1, when you suspect, it's not likely that you will get a confirmation that this is monkeypox only, and therefore having a greater net of protection would always help. So a negative pressure ventilation with adequate cross ventilation. People could be cohorted in an isolation ward, or they could be put into individual rooms But whichever be the isolation facility, it should have its own hand washing facility and a bathroom. And naturally, as we mentioned earlier, also precautions, isolation precautions should be continued till normal skin is actually formed underneath the area where the lesion was present. So with that, my final takeaways from the current epidemic of the monkeypox is that WHO declared this as a public health emergency of international concern because of clusters appearing in non-endemic settings. The transmission is mainly due to close skin-to-skin contact and the droplet route. Watch for atypical presentations in your clinical settings. Please notify local authorities to take up the case further and advise on what else is to be done, and particularly with isolation. In the community, isolate, limit contact, perform hand hygiene at every opportunity, and use disinfectants which are locally available. Similarly, in the healthcare setting, standard contact plus droplet or airborne precautions should be taken. And once again, environmental cleaning and disinfection becomes very, very important even in healthcare facilities. So with that, I'd like to thank you all for your patient attention. And I would hand over to the next speaker, Dr. Kirti. Thank you.
Yes, thank you so much, Dr. Pujari. I think you have made it amply clear. And as you rightly said, COVID has made us slightly wiser. We have become slightly more apt at using masks, using gloves, and the disinfection procedures. But somewhere the laxity, once COVID cases started going down, the laxity has come into our actions and behaviors while dealing with the patient. So it is time once again that we step up our the watchful glasses, and we take utmost care of ourselves, because if we take care of ourselves, we are going to be able to take care of our patients. You have explained wonderfully well how the disease is, it enters into the humans, which are secondary hosts, and it gets transmitted, and what are the precautions and the preventive measures that we are supposed to take. So with this, we'll be inviting question answers. I guess we'll be taking up at the end. Is that okay, ma'am?
No problem.
So we'll be taking for whatever other question answers coming in towards the end. So with this, I introduce the next speaker. Please give me a minute to share my screen. Yes. So with this, we have our next speaker, who's Dr. Kirti Sabnis. She is postdoctoral fellow in infectious diseases from MGR University and Christian Medical College, Vellore, former assistant professor at CMC Vellore, and currently she is infectious disease consultant at Fortis Hospital, Mumbai. And she is going to tell us about clinical presentation, complications, and treatment of monkeypox. So welcome, Dr. Sabnis, and the stage is yours. Please take it over.
Thank you, Dr. Archana, for a kind introduction and a warm welcome. It's always pleasure to be with Dombivli. I'm actually like a regular. I either attend or speak. So it's really a pleasure. Without any further delay, I think we should start our presentation. I'll just share my screen. Is my slides visible?
Yes, Kirti, yes.
So actually, Dr. Aruna has made my this thing very easy, because majority of what currently we have is actually a very good infection control practices, because as we discussed, we will see that majority of the illness is self-limiting, and a handful of patients like in COVID have complications. In COVID, we had a lot of numbers with complications because many people were infected. The current outbreak is still brewing, so we yet don't know what will be the impact on overall community. So currently what we have is early identification, suspicion, and good isolation practices. So again, the importance of hand hygiene, which is very prime importance and close to heart to all the infectious disease consultants, infectious disease nurses, and microbiologists, is really, really important. So this will be the outline of my talk. We'll see how to differentiate it from a common acute viral exanthem, which is very common now because of the overall monsoon season. Also, what are the complications? As we know, there has been one death in a pretty young boy with monkeypox. What can be the complications? What are the treatment options currently available with us? And in short, brief, what can be prevention? Mainly vaccines. So it is a zoonotic but rarely life-threatening disease. As Dr. Aruna has already covered, I'll quickly go through this. Mainly what we need to focus in this is a spread from animal to human and from human to human. Also a fomite spread from shared towels, contaminated bedding is very, very important to keep in mind. So is it new, or it is a mutated virus, like we are seeing a lot of mutations in COVID, or it is an old virus? So this has been known to us since almost 1988, 1978. So whether there is still a debate, there is still a research going on, whether we have, as we have changed overall, a slight change in the presentation, slight change in the mortality, whether we have any new mutations, the research is still going on. There are already 2 clades which Dr. Aruna has explained to us, and still we have what current outbreak is with the West African strain. So prior to 2022, there were sporadic cases. We have a graphical representation also. We'll go through that. So these are the areas which are in purple, lavender color, are known to have endemic monkeypox. But there also the cases are not like outbreaks or pandemic. It is sporadic cases with a definite history of contact. But now it has spread across the globe. And as we see, there might be few changes in the transmission, as we are seeing slightly more cases since last May. This May 22. And there's also outside endemic Africa, we are seeing increased number of cases. Yet to comment on a number of deaths or mortality or fatality, it's very early, but we are seeing up to 6%, which is not very rare to have in monkeypox. Overall fatality noted is up to 11%. So in India, as Dr. Archana has already said, there are 8 to 9 suspected cases, 4 confirmed cases, and 1 death. As I said, the risk of death is up to 10%. Current overall outbreak has around 6% of the death rate. And we'll see in short what are the risk factors for death, what are the risk factors for complication, and how to look for the complications. There are 1 or 2 suspected cases which don't have a history of travel or history of contact with the travel people. But Government of India still now has not confirmed any community spread as yet. So it is strictly with the travel history as of now. So these are the classical lesions. As we see, this is a acute febrile viral exanthem. So it is a pox. So it is a violated red violaceous lesions, mainly involving hands and face, multiple, and differentiating between these and other, we'll see in a few slides next also. It is very important is these are well circumscribed, these are very deep seated, and these are painful. So this is very classical of monkeypox. So it is a viral exanthem. So there is a prodrome which lasts up to 5 days, and there is an acute rash period which can last up to 14 days. So like this, total 20-21 days of the disease period which normally we see. So fever, chills, myalgias with rash. This is a classical presentation. There can be lymphadenopathy. There can be, typically in seropositive patients, also been reported to have epiglottitis, conjunctivitis, scleritis. It's also known complications of monkeypox. And generally they develop after 5 days, but before 14 days of contact with the index case. So another very important factor, which I think as a general practitioner, as a surgeons, and as gynecologist, as urologist, we should know is typically increasing cases. Even the kid 22-year-old kid who died also had a rectal or genital ulcer, scrotal ulcer. So this is a very different presentation than what we have seen typically before 2022. Generally, the ulcers can be limited to genital and rectal area. Few cases, as I said, epiglottitis or oral lesions without an initial prodrome are also seen. So typically this history of fever, chills, myalgia might not be always present. So if you have a patient who is coming with the travel history and a genital ulcer, obviously this is a new thing. This is not like any patient who is coming to you with the genital ulcer is not going to be monkeypox, definitely. But after ruling out routine STDs and routine transmitted diseases, we should definitely keep in mind about monkeypox. So whenever the patient comes to you with a genital rash or fever and coryza, common isolation standard precaution should be followed by the clinicians also. Because a reduction in number of COVID cases, we also been little casual about the infection control and isolation practices in our day-to-day clinic. So a rash, it typically begins within 1 to 4 days of appearance of fever, continues for a period of 2 to 3 weeks. New rash appearance also can continue up to 2 weeks. The rash tend to be more concentrated on face, also on palm, hand, and sole. Other areas include oral mucous membrane, conjunctiva, anal area, and genitalia. The lesions generally, as we have seen in the pictures before also, generally they crust over and this crust dry up and then fall off. So the isolation is typically until the crust is fallen off and the new skin appears. So generally becomes 14 days after the rash onset, or total 21 days after the rash onset is the safe isolation period. But the isolation period can vary. We might need to extend it beyond 21 days if the rash is still continuing or if the rash is still not healed or scaled. So slow healing of the rash can happen in people who are underlying immunocompromised, either on steroid, on chemotherapy, HIV. So these patients tend to have a slow healing rash, and unlike other rashes, this rash can be painful, and eventually when it heals, it can be itchy. So what are the complications? Generally the complication or death are not because of the rash. Obviously the death is mainly commonest complication leading to death is actually pneumonia, sepsis, and very important encephalitis. So it's a very important cause for a septic meningitis in a given particular setting if it fits in. Also there can be vision loss because of the keratitis and scleritis. And how much percentage of infections actually remain asymptomatic, we are not able to fathom, but overall whatever the 2 NEGM papers have been published, the asymptomatic infections can be up to 20%, but this figure might change and evolve. As I've already mentioned, the fatality ratio of monkeypox is up to 11%, and the specific vulnerable group remains children and pregnant females. So other differential diagnosis, in short, we have to put is a differential diagnosis of acute exanthem with fever as an acute exanthematous rash. So varicella, herpes, other STDs, smallpox. Obviously, we don't have de novo transmission of smallpox anymore, except few areas in Pakistan and Afghanistan. Other pox viruses. The other pox viruses includes camel pox, cow pox, Alaska pox. So they are very specific to the areas. After they will have definite travel history to these areas, mainly Alaska. So how to differentiate between a monkeypox, chickenpox, and measles? So generally the rash in measles is a non-vesicular rash. So there itself we differentiate between monkeypox and a measles. So rash with vesicle papules, obviously then we need to differentiate between a monkeypox and a chickenpox. Generally the rash onset is slightly delayed in monkeypox than in chickenpox by 24 to 48 hours. The rash appears in chickenpox as crops. Mainly it is called a centripetal, so it appears on chest as well as on face. But for monkeypox, generally this episode the rash is also appearing on genital area, but mainly appears on face and then spreads to the chest. So it's opposite of the chickenpox, and generally the involvement of palm and sole is late in chickenpox, versus in monkeypox we see early involvement of palm and sole within a week of onset of rash. So I think the crux point which we can differentiate is appearance of rash after fever if they have, and the distribution of rash is very typical, involving palm and sole and not involving palm and sole. So I think then it becomes common with general practitioner who deal with a lot of pediatric cases. The next differential diagnosis which involves the mouth, palm and sole is hand, foot, mouth disease, which is also very common nowadays in kids. So how to differentiate between a hand, foot, mouth disease and a monkeypox? So generally we don't have any lymphadenopathy in hand, foot, mouth disease, and there can be a lymphadenopathy in smallpox. And the typical rash is very painful in monkeypox. The rash is not that painful with hand, foot, mouth disease. And generally the disease onset is very short, 7 to 10 days it resolves, and generally the disease on duration is very prolonged. For monkeypox can last up to 3 to 4 weeks. And obviously there is also a history of travel. Generally history in newborns it will be difficult to pediatric age group, it will be initially difficult to differentiate, but as the rash evolves, we will be able to differentiate between the hand, foot, mouth disease. But currently, without travel history or without a history of contact with a travel person, we are not considering monkeypox even in pediatrics. So when you suspect the diagnosis, now we have seen a rash, we have seen so many associated features like fever, joint pain, which are very common. In alternate patient in your OPD in monsoon is going to be either of these symptoms. So when to suspect, as I said, consistent rash with either one of the following is epidemiological risk factor, that is close or intimate contact or social network experience in areas or in patients who have diagnosed to have monkeypox. Like patient who had, the first patient in Kerala had a history of close contact with a patient who was diagnosed to have monkeypox by the time the patient traveled to Kerala. So this is very important. That is called as epidemiological risk factor. Second is recent travel to his endemic areas is very important, Central or West Africa, or other areas like in a few areas in UK and US where outbreaks of monkeypox have been reported. Also, as I said already, it's very important patients who don't fall in this group, but have typical lesions, mainly genital ulcers or proctitis in MSM. Sometimes we might not be able to elicit the history of MSM in these cases, and we are treating them as STD, and they are not responding to the empirical treatment with STD within first 4 to 5 days. They should be considered to isolate and diagnose as monkeypox, taking samples, as we already Dr. Aruna has told us. Another very important commonly asked question is sexual transmission and infection prevention practices for monkeypox. It is not typically labeled as STD yet, but yes, as the NEGM paper we see, which was published in May, almost 90 to 95% in that particular cluster, people had a history of contact with men having sex with men, and there was 90 to 95% transmission. There were people who were heterosexual, but common in homosexuals, obviously. And very important as a infection control measures, this is according to CDC, we need at least 12 months of barrier precautions, that is contraception, for a known documented case of monkeypox. So we'll go quickly now, as we have a lot of discussions to case-based, we a lot of have questions and discussions, sessions remaining. So treatment options, these are the 2 vaccines which are available and a few oral agents, 2-3 oral agents which are available yet as a treatment. But unfortunately in India, currently, we don't have either of this available. Neither we have both the vaccines, neither we have ticorivimat. Cidofir is yes available. We use as a part of cytomegalovirus infection as a second line of therapy. So that is available. Except cidofovir, currently, if you suspect a case of monkeypox with you in your OPD, we, as Dr. Aruna has told us, we have to refer the patient to, in Mumbai, we have to refer the patient to Kasturba, and they will try to procure, if possible, from CDC, because ticorivimat is strictly procured from CDC in high-risk cases. and other 2 vaccines are also with CDC and 1 center in Russia. So, but this is not to scare. Majority of the patients have milder illness. Generally, they require supportive care with to stop dehydration, vomiting, pain, dysphagia. That's it. They generally don't have severe cases. Severity is only 15 to 20 of total monkeypox, which has been known. So, who are the patients who need admission or special attention? The list is little exhaustive. I've tried to put all the patients who require. So, patient with severe disease require hospitalization. Who are the patients? How do we identify whether the disease is severe? Hemorrhagic diseases like conjunctivitis, hemoptysis, pneumonitis, extensive confluent skin lesions like we say in Stevens-Johnson. Patients who have a suspicion or diagnosed encephalitis, these will require hospitalization, and these might require specific antiviral therapy. Patients who have risk of severe disease, like patients with HIV, leukemia, lymphoma, pediatric population age less than 8 years of age, pregnancy, breastfeeding, patients who have previous history of atopic dermatitis or exfoliative skin conditions like Stevens-Johnson. These are the patients who will need to get admitted. A specific antiviral therapy only for, as I said, immunocompromised and severe cases. So what are those therapies? Only tried this drug specifically for monkeypox. It is for actually for orthopox. It is also been tried for smallpox. Is ticorvirimat. It's also oral and IV formulation is available. It disrupts the cell wall of the virus, and that's why that's how it acts. The total duration of treatment is 14 days, and 600 milligram twice a day is a dose. We don't have a safety data available for pregnancy. We don't have a safety data available for kids less than 8 years, which are actually vulnerable. But risk versus the benefit, this has been tried. But whether if we give it to the mother who is pregnant, and if that dose protects the child who is born is not known. If you suspect, because there is a fetal to mother to fetus transmission, if you suspect that the mother is the baby is infected because of the pregnancy and fetal transmission, placental transmission, we need to treat the baby separately. So this is the only trial which has been available. FDA approved it in 2018, and this has been actually non-human primates. It has been tried, and no major side effects have been noticed. Cidofovir, yes, it has been also has an activity against monkeypox, and it is we have not been that much trials are not available. There's only case reports of cidofovir and brincidofovir. Brincidofovir is easy oral option for monkeypox. There is also a vaccinia specific immunoglobulin where we can't use the antivirals. That has been severe cases where cidofovir and immunoglobulin have been tried single or in combination. So now we are coming to a very important aspect, which is very close to everybody, because with COVID, everybody is thinking vaccine will protect us. So where are we standing in terms of vaccination for monkeypox? So as it is an orthomyxovirus, so smallpox vaccination, which was a routine part of our vaccination up to 1979. So people who are born, who have before 1979 and who have received a smallpox vaccine, they have a good news, almost 80 to 85% protection against at least the severe form of monkeypox. That has been documented. People who are born after 1979 have not received, or some reason have not received the smallpox vaccination. They might be a candidate for either pre-exposure vaccination or post-exposure vaccination. So how it stands for a pre and post-exposure vaccination. So pre-exposure vaccination is currently been recommended only for laboratory workers who are handling the cultures or handling the animals or infected animals or infected humans. So this is the CDC recommendation. Also, certain healthcare and public health response teams who go to the public health authorities, mainly in Central and West Africa, where they work. So it has been devised for them. These people should get a pre-exposure prophylaxis vaccine. So it's a live vaccine, also known as MVA, M1X. So this has been licensed in 2019. This is licensed only in adults age 18 and more. Another vaccine which has been getting developed for also kids is ACAM 2000. This is also a live vaccine. the recommendations for ACAM 2000 are slightly less efficacious than IMVAX, because that has been in use more than ACM 2000. So this is a comparison between the two. Adverse effects which I need to highlight is myocarditis, and the risk, that's why the MVAX is more been in vogue, because lesser side effects. And these are multiple punctures. This is intradermal is a best route, and this is subcute. It's a single dose, ICAM 2000, and AMVAC is 2 doses, like same like Covaxin we take, 28 days apart. So what should we do? Now, if you have a suspected case, a patient has come to your OPD with all symptoms of cough, coryza, and possible non-resolving genital rash, what should we do? As we know, patient needs a complete isolation. Patient also will need a risk stratification, mild, severe, and other immunocompromising condition whether the patient has. And we need to inform through the EPID cell, that is the must. Sample collection and diagnosis confirmation is entirely done by the EPID cell. Any normal commercial lab, we don't have the test to be offered to any of our patients. So high risk exposure, they definitely need to get vaccine. Intermediate exposure, who have close unprotected contact through bathing, dressing, transferring, this risk of exposure and vaccination needs to be decided case to case basis. And low or uncertain risk exposure is patients who have very low exposure, which is not coming in intermediate and high risk. So these patients who are coming in moderate to low risk, we need to high risk to moderate risk need to get vaccinated within 4 days of exposure, and up to maximum 14 days they can take vaccine. Antivirals, yes, they are being offered, but we don't have any data for protection, and currently antivirals are not available with us. Special mention for pregnancy and monkeypox, as there is a fetal transmission noted. A close monitoring for severe disease, and if you really have a patient who is suspected to have monkeypox or confirmed monkeypox, then the antivirals needs to be administered to reduce the pregnancy complication and adverse outcomes. But currently we don't have. This has to go to the government of India, and from here in Mumbai it is Kasturba, and they will try to procure the treatments for the patient. In a nutshell, clinical suspicion is very important. Very important is isolation of suspected cases. Diagnosis is only confirmed by PCR, and mortality is not very common. Therapy is largely symptomatic. Thank you.
So, Dr. Kirti, that was really very comprehensive, and I think you've given a fair idea about how people are supposed to be suspecting. And as you rightly said, presently, like how we had in COVID, it was initially related to the history of travel. So presently, the diagnosis is related to a history of travel in affected countries in past 21 days. Please correct me if I'm wrong. This is the current guideline which says
recommendation.
So in last 21 days, if the patient has either traveled or has come in contact with somebody who has had monkeypox in past 21 days, and they present with any of these symptoms, as madam said, that is fever, all other symptoms of viremia, headache, body ache, swollen lymph nodes, and the rashes, then yes, they do become candidates where we need to start suspecting monkeypox, more prominent in children and problematic in pregnant women. But we need to have a high index of suspicion for diagnosing these cases. As it is, I hope everybody is aware that any fever with rashes are reportable cases to the epidemiology cell, whichever municipal corporation you belong to. So all fever with rashes are technically to be reported to your epidemiological departments of the corporation. So please do that diligently. And with this, we have some questions which have come in. So should we take them, madam?
Yeah.
Yes. So till now, I'll be just taking up questions which have come in the chat box. Meanwhile, if anybody else wishes to ask a question, you may please either type it in the chat box or you can raise your hand, and I will invite you to ask your own question. So, madam, how is the availability of vaccine and who gives?
Fortunately, right now we don't have vaccines available as a commercial use. if people, because largely up to 1979 the vaccine was there been used, so only the younger generation 30 and above, 30 and lesser will not be vaccinated. So large population of India is going to get a cross protection most of the cases. But if anybody wants to, like, I want to take COVID vaccine, like that I want to take smallpox vaccine, we, or specific monkeypox vaccine, we don't have.
It is not available. Okay. So whatever treatment, as you said, if the patient is suspected, you want to give any post-exposure prophylaxis also, they have to be sent to Kasturba. That is limited for Mumbai we are talking about. Rest of the places, because we have got people over here who have joined from different parts of India also. So you will have to find out from, your region, which are the
their government
hospitals.
hospital,
Yes.
They have a separate cell, so they will
They
will not be able to administer them immediately. They will separate, isolate them, and then
absolutely,
get it
absolutely. So please confirm which are the infectious disease hospitals in your area, and these things will be applicable to those hospitals also. Madam, we have a question. What is generally the CBC picture in monkeypox?
CBC picture in monkeypox is it's a viral illness, so they will have monocytosis. That's the commonest thing, and very rarely when they have complications like pericarditis, they can have sepsis and pneumonia. The CBC picture might change, but otherwise the distinctive feature is monocytosis. In rather than lymphopenia, we have monocytosis. Like we say in COVID, there is lymphopenia. Here is specifically monocytosis.
And there will be leukopenia, which will be expected generally.
Yeah, it's a viral illness. We have relative leukopenia, but it's mainly the monocytosis which is striking. Right. But that can't be a criteria for diagnosis.
Absolutely. So criteria for diagnosis is basically clinical, and otherwise, if in suspected cases, it is basically the lesions which we scrape or we take fluid from, and to be sent only to NIV, if I'm correct, only to NIV Pune, and this is not done by us as private practitioners. The patients are to be referred to the infectious hospitals, and these hospitals will be doing the collection. So our job as of now remains is to identify the patients and report them to the authorities. Okay, so
until that they have to be isolated.
Yes, until then, yes, and we can give them the symptomatic treatment regarding whatever are their problems. Okay, so question, any existing available antiviral can be used?
We have cidofovir, yes, which can be used definitely for cases who have high risk of complication like pregnancy. Cidofovir has also been used in pediatric age group. So cidofovir, currently, if you have any suspected case who is really having complication, encephalitis, I will urge to have a diagnosis, because cidofovir is potentially hepatotoxic. Cidofovir is current right now, which is available with us in India.
So, but then our cidofovir, should our doctors be prescribing by themselves if they suspect in a high-risk patient, or should they be sending the patients across to a hospital which is equipped to be treating?
All patients have to be sent. All patients have to be sent to the infectious disease hospitals or government hospitals. We currently don't have.
Exactly.
If you give cidofovir, because it is available, but it is not the drug of choice, and there is also a lot of contact tracing and isolation which is involved, so which will not be possible as a private practitioners to us. So it is better to refer patient.
Yes, because if by chance you give cidofovir and the patient really turns out to be a monkeypox and you have not reported to the authority, you are in a big problem. Please understand that. Okay. Yes. So is the rash painful right from the time that it begins, that is the maculopapular stage? So is the rash painful right from that stage, or where it becomes, pustular or vesicular? That time
no, right. Rash is painful from the beginning. What discussion which we had with in our infectious disease community who handled the first case of the monkeypox, the person had a single genital ulcer. It was behind the scrotum and it was painful from the beginning. Okay. Actually, the pain reduces after day 7.
Okay. Madam, Aruna Madam, can you please say what is the rationale behind not using VTM for sample collection?
So basically, from the main specimens that are to be collected are the skin lesions, the aspirate, the biopsy. They don't get dried very quickly. So a VTM basically supports your viral materials to be, viable for a longer time. So that's the only rationale for a VTM to be used. And here, basically, it's the lesions which don't get dry. So that is the reason why you should not add any VTM or not add the lesion material to a VTM. It's not required. It will create additional dilution, in fact.
So just the point to be noted by everyone, as and when the samples are created, either whether it is scraping of the roof or, collection of the fluid from, the pustules, it is always to be sent across in a plain bulb, not to be done by us, to be done by the infectious disease hospitals. Okay.
Yes, yes. I think
Yeah.
that is the key. Don't do
Yes.
anything by yourself. Send the patient to the local
These are now
municipal authority.
notifiable diseases, and we
Yes.
cannot play when the diseases are notifiable diseases. It is our job, primary job. One is to have a high index of suspicion. Second is to advise them to isolate themselves so that in case the lesions develop and they start looking like those of monkeypox, by then at least the others in the family and the contacts would be protected. And third, of course, most important, treat the primary symptoms, what you are saying, seeing, in a symptomatic manner, and inform your authorities. Okay, so I think that is probably the thing that you should take home from this webinar. Okay, so madam, the next question here is, okay, can you speak more about the maternal fetal transmission?
So mother to fetus transmission is noted early itself in the from the second trimester, and there can be preterm deliveries, there can be adverse outcomes noted with monkeypox, and there can be also, yet there is not a very clarity, but there are few cases reports are of a congenital monkeypox also has been noted. So as I said, these are the cases which are high risk of maternal complication, high risk of fetal complication in terms of intrauterine death and preterm deliveries and complications related with it. No specific congenital marker abnormality like we see in Zika, like that is not been noted, but there can be a congenital monkeypox. So to prevent it, we have the drug which has been approved actually is ticorvirimat. But whether it has any teratogenic or other effects, it is not known. Okay. So we don't have that drug available with us. So if we have a pregnant lady with confirmed monkeypox, we have to get it from CDC.
Okay, okay. Okay, Aruna madam, can you please speak more about, this triple layer packaging that you spoke about, while transmitting the samples?
So the triple layer packaging basically comprises of something that will not allow any liquid material to leak out, So externally you could have a cardboard box, and then again on the inside you could have another cardboard box, and you could have another non-porous container which is lined by absorbent material, like cotton or gauze, into which you will place your specimens. So that's how a triple layer packaging is to be done. Plus, on the external surface, ensure that the biohazard label is applied so that whoever is handling or transporting would know that this has to be taken care of.
And this should be transported in ice.
Yes, yes, of course.
The cold chain has to be maintained. Yes.
Yes.
Okay. So, madam, what is the advisory for healthcare workers or close contacts who have come in contact with monkeypox patient, either, a suspect or a confirmed patient? So if they have come in contact without the use of protective gear, so then what is the advisory for them? Because in COVID, we have clear-cut guidelines, like if you are a close contact, you have come in contact with a COVID, either a probable patient or, a confirmed patient, and these are the things that you are supposed to do. So what do we tell the healthcare workers and the close contacts who have come in contact without use of precautions with the confirmed or suspect patients?
So I think just like COVID, here also the primary measure is to isolate, and second is you would naturally want to inform either your superior or your general practitioner or whoever your healthcare worker, meaning whoever is going to take care of you from the point of view if you are a family member. So inform them so that they can inform the authorities. So and remain isolated. I think Kirti also mentioned this earlier. Remain isolated and wait for lesions to develop. So for a total duration of at least 3 weeks, the person, whoever is exposed to a suspected or a confirmed person, needs to be isolated. So unlike COVID, the duration here is really large.
Yes.
3 weeks is a long time.
Yes.
But generally, if the rash is to be happening, it will generally happen between 7 days, maximum to 21 days. But what the CDC says is, because if suppose it is not the condition like we are in a pandemic of monkeypox, but because of the longer incubation period, suppose the time comes that there are a lot of cases, including even the healthcare facilities, then the people, like in COVID isolation, we started asymptomatic patients, asymptomatic healthcare workers after 5 days not developing symptoms can wear an N95 and work. Similarly, there have been recommendations for asymptomatic close contacts. They can do isolation precautions and still work, like healthcare workers still can work. So there is a small recommendation for that, but as the time evolves the recommendations might change further. But they have allowed healthcare workers who are completely asymptomatic with the contact, maintaining the close contact precautions, like not having close contact with the family members, and to work.
Okay, so the patient may be infectious even in the prodromal period before they form the rashes, and
yes,
so the care will have to be taken right from the time the patient starts running fever till the time all the scabs fall off and new skin comes in. So that is going to be a huge incubation or rather isolation period for the patients who are there. Okay, so I think that almost covers it all. And the last question, because if anybody has any questions, please do ask, or I'm just going to ask the last questions. Current travel advisory. What is the current travel advisory?
Advisory is will be changing because it is not like the number of cases are not like COVID. There are no travel restrictions, but for people, if you're going to the known endemic areas, like the new endemic areas, the known endemic areas for monkeypox was Central and Western Africa. Other than that, there are pockets in UK and US which have been more than normal cases of monkeypox have been reported. If you're going to travel in those areas, definitely you should avoid the contact with sick people, people with obvious rash and coryza and cough should not. And as I said, the 90 to 95% cases have been actually reported with an MSM or a heterosexual activity. So high risk drug and sexual activity should be avoided for everyone who is going to travel to the anywhere. I will suggest, because we don't know cases are going to come from where.
As Madam has said, you know, it has gone across in about 85 countries are reporting now cases of monkeypox. Okay, so this is, you know, one question has come in. How many days isolation for the contacts? And second is, does one attack offer lifelong immunity? How many days
isolation remains the same. I think 21 days till of course, you know, you have such large numbers that you will be forced to reduce it. But it remains 21 days till now. And I think it's similar to smallpox, you know, meaning one attack will remain, you will give you lifelong immunity, because that's how this particular pox viridae really go about.
Yes, yes. So this 21 days basically is because it has got a longer incubation period. The general incubation period is, I think, from 6 to 13 days, but otherwise it can come from 5 days up to 21 days. So that is the reason here 21 days of isolation or separation is being asked for. So
pre-exposure, the infection is from the rash, no? The infection is from even the rash can contain the virus. The secretions can contain the virus. So until the rash is secreting,
no, here it is being asked for the contacts. Here it is being asked for the contacts, not for the patient.
It has a longer duration of incubation. Yeah. It has a longer duration of incubation, and meaning for those ones who are asymptomatic, of course, a longer duration of incubation. Those who are symptomatic, naturally, we have said that evolution of the rash takes a long time.
Right, right. So, Madam, I think that finishes our session, and you both have been really, really wonderful. And I think monkeypox as a disease, as you know, we understand any disease as it evolves, as it progresses. And yes, this is an evolving disease. You know, we'll know more about it probably as it starts showing its notoriety. But till then, I think we have made the things quite amply clear for everyone who's here with us today. We'll try to upload today's session on YouTube, and I'll be sending the links across to people. Before we finish, to my both speakers, you know, I would like to ask both of you one after the other, what are your take-home messages? Dr. Pujari, we start with you. What's your take-home message?
So I think we really need to have a high degree of suspicion for cases. Two, it's not something that you cannot destroy easily. So don't go overboard on panicking. Three, you have a huge population who was probably vaccinated with smallpox vaccine. Use them to take care of people who might, you know, meaning we are not going to be alone, isolated, like what happened with COVID. we can have people to look after such people. So, that is important. And don't panic. I'm sure we'll be able to handle whatever comes.
Absolutely, absolutely. So rightly said that there's nothing to panic. The only thing is just be careful. And I think viruses are going to be dominating the world. I mean, if there is anything which we have learned in last 2 years, that it's going to be viruses which are going to be dominating the human race. So I think this high index of, that taking care of ourselves, rather the masks and the sanitizers and keeping a distance and not coming in close contact in crowd, I think these should be our lifestyles forever, because probably these are the ones which are going to be saving us for a long time to come. So thank you so much, ma'am, for that wonderful insight. And now I come to you, Dr. Sabnis, for your take-home message.
It is always pleasure to talk to Dombivli with Dr. Archana. I think as an ID physician, rash is always a matter of concern. So there are two aspects of take-home message. One is the take-home message for practitioners themselves. Treat all the cases of rash and fever with utmost infectious disease, infection control prevention, wear gloves, wear mask, and then only handle the patients. Because if it turns out to be a monkeypox, you will be isolated for 21 days, even if you don't have symptoms. And another thing for the patients as a caregiver, I think we don't need to panic. We have enough information from handling COVID. So without hesitation, I think we should ask for help. If you have a suspected monkeypox case, refer that to your regional municipal hospital. Let it be negative rather than keeping the patient and then turn him up having complication. Refer the patient early. It's okay to ask the patient to go and give the sample and come and stay in isolation.
True. And madam, one more question before we finish. I want to ask that all the viral illnesses are known to give rise to a little bit of rash here and there. Some viral exanthema, we do see a little bit of at least macular rashes somewhere. So anybody who's having, symptoms, a lot of cough or a lot of cold or a lot of soreness of throat, should they be more suspicious about, H1N1 or the seasonal flus or the COVIDs right now? Because we will just make it, all round webinar wherein, because these are highly on the rise. At least this is what we are seeing in Dombivli, that H1N1 is really, really on the rise. So would you want to give some pointers over there? Because any rash, otherwise it is going to be labeled as monkeypox with more awareness of monkeypox coming in.
How, as a clinician, as an ID clinician, I'll go about it is, it's very important to see the onset and travel history. That's first part. Second, okay, if it becomes an endemic, like it happened with COVID initially cases only with the travel, then it started to have our own cases. Then I think what happens in monkeypox is the rash from the beginning is little like a papule. It's not to initial like a macule initially, and hand and sole involvement is very early. Palm and sole involvement is very early. So these, I think, two important pointers which will tell us, and genital involvement of the rash.
And do you really see the mouth, this emanthema, what they speak about, like Koplik spots and all? Do you really?
The epiglottitis has been known in HIV patients. It has been a very known complication, but this variant, which is CLE2, might be having more of a genital regions than mouth. Actually, that's what been seen in last few months cases.
So great. I think with this, we can, end this session. And I think people are, given enough information that they should be able to take some good care of themselves and their patients. And so we will try to come back soon with, information about something more. In 10 days time, we are trying to have an update on TB, what is new in the NTEP. And surely we'll be circulating information to everybody. Mind you, if you want to learn something which is, knowledge oriented, please always don't go for the MMC credit points. So yes, this webinar was without MMC credit points. So I hope I do not keep receiving mails that when are the MMC credit points going to be given. So yes, with this, we end the seminar today. And thank you so much, Dr. Aruna, Dr. Kirti, for that wonderful, insightful session. Until we all meet again next, it's goodbye to everybody. Thank you so much.
Thank you so much. Thank
you.
Bye, Kirti. Thank you. Thank you, Dr. Patil.